Hi, I'll be continuing with the antifungal drugs in continuation with the previous class. So today I'm going to start off with allylamine. The first drug under the allylamine is terbinafine. This is actually a topically as well as orally active drug. Orally as well as topically active drug, and it's active against dermatophytes, Candida albicans. Okay, so it is very active against dermatophytes, Candida, and also if you see its activity, they are said to be fungicidal, and short duration course will be applied in this particular case when we are going for terbinafine application. Okay, so the short course treatment regimens will be followed, and if you see the relapse rates, that there is only very low relapse rates associated to this particular drug. Now let's talk about the pharmacokinetics. Now pharmacokinetics, approximately 75% of the oral terbinafine will be absorbed. 75% will be absorbed, and only 5% or less will be absorbed from the unbroken skin. After that, they will undergo first pass metabolism. Okay, they will be undergoing a first pass metabolism, which further reduces the oral bioavailability. It is said to be lipophilic, and it gets widely distributed in the body. Strongly it gets bound to the plasma protein, and it gets concentrated in sebum, stratum corneum, and the nail plates. It is inactivated by metabolism, and it is excreted. Around 80% gets excreted in the urine and 20% in feces. The half-life is said to be 11 to 16 hours, and it gets prolonged to 10 days after repeated dosing. Okay, so this is all about its pharmacokinetics. So if you talk about pharmacokinetics, 75% of the oral dose will be absorbed, but only 5% or less from the unbroken skin. First pass metabolism will further reduce the oral bioavailability. It is said to be lipophilic. It gets widely distributed in the body, strongly plasma protein bound, and it gets concentrated in the sebum, stratum corneum, as well as in the nail plates. It is inactivated by metabolism and excreted in urine, approximately around 80%, and 20% of it gets excreted in the feces. The half-life is said to be 11 to 16 hours, and it gets prolonged to 10 days after repeated dosing. Now let's have a look at about its uses. Topically as 1% cream, or orally 250 milligrams OD in tinea pedis or corpus or cruris, or in case of capitis, pityriasis versicolor, and it will be given as a 2 to 6 weeks treatment regimen according to the site. Then in case of onychomycosis, 3 to 12 months oral therapy will be given. Efficacy in toenail infection is just 60 to 80%. It is very less effective in cutaneous as well as in case of mucosal candidiasis, and here 2 to 4 weeks oral therapy will be used as an alternative to fluconazole. Now side effects. In case of oral administration of terbinafine, we need to expect gastric upset, rashes, taste disturbances, hepatic dysfunction, hematological disorder, severe cutaneous reactions. And in case of topical, we can expect erythema, that is redness of the skin with that be rashes, itching will be there, dryness, irritation, urticaria, and redness can also be seen along with the rash formation. So this is all about the tubular film. Now let's have a glance about the other topical antifungals which are used in the treatment. Now usually these are used for the treatment of dermatophytosis. These particular drugs, the following drugs will be used. The first one is tall naphtate. Now this is very effective against tinea cruris and tinea corporis. And this will be given for 1 to 3 weeks duration. The treatment will be followed for a period of 1 to 3 weeks. Now it is very less effective in case of tinea pedis and other hyperkeratinized lesions, tinea capitis, which even involves the scalp, tinea unguium, that is involving the nails, due to the poor penetrability. Okay, so due to this particular aspect, they are not used in these particular conditions. Symptomatic relief will occur very early, but if they are discontinued before the fungus bearing tissue is shed, then there are chances of relapse. No resistance can be noticed. Salicylic acid can help, or it aids the tall naphtate by keratolytic action. So you can combine it with salicylic acid in case of the treatment regimen if it requires the usage of salicylic acid. It causes very little irritation, but is not effective in candidiasis or other types of superficial mycosis. So this is what you need to remember about tall naphtate. Alright, now the next topical antifungal, cyclopyrex-olamine. Now this is effective in case of tinea infections, pityriasis versicolor, and dermal candidiasis, and it has got a very high cure rate, so it is very useful in these disease conditions, and it penetrates the superficial layers and reaches the hair roots. Okay, it goes through the superficial layers, reaches the hair roots, but excuse me, systemic absorption is negligible. And it is used in onychomycosis and in case of vaginal candidiasis. The next drug, andesylinic acid. It is said to be fungistatic. It is used topically because it is coming under the topical antifungal, so it is used topically, and it is generally used in combination with zinc salt. The cure rates are very low. Low cure rates can be noticed here, and irritation and sensitization are infrequent. Uses in case of tinea pedis, in case of nappy rash, and tinea cruris. Benzoic acid, the next topical antifungal, benzoic acid. It is antifungal as well as antibacterial properties could also be noticed in this particular drug, and it is said to be slightly acidic medium. It is fungistatic, and eradication of the fungus needs prolonged application till the infected keratin is shed. So till it gets shed off, you will have to go for applying this particular drug. On hyperkeratotic lesions, it will be used in combination with salicylic acid. Like for example, it is available in the markets as Whitfield's ointment. Okay, so Whitfield ointment, it is a combination of benzoic acid and salicylic acid, and it will be used in case of hyperkeratosis lesions. Then the latter, by the keratolytic action, helps to remove the infected tissue. Okay, the salicylic acid, it will be providing, or it will be having an important role in removing the infected tissue because of the keratolytic action, and it promotes the penetration of the benzoic acid into the lesion. Irritation and burning sensation can be experienced, and it has been reported by many patients during the treatment regimen. Now moving on to the next topical antifungal drug, buprenorphine. Buprenorphine. It is a benzylamine congener of terbinafine. Benzylamine congener of terbinafine with the same mechanism of action like the of a terbinafine. Now uses topically, they are used for dermatophytosis, and it is very efficient in case of tinea cruris, corporis, pedis, and it is almost similar to the topical way. The next particular drug, quinidochlor. Quinidochlor. By the oral route, this can be used as an amebicide. It possesses weak antifungal as well as antibacterial property. On external application, it has been used for dermatophytosis, mycosis, seborrheic dermatitis, infected eczema, furunculosis, pityriasis versicolor, and also it is used in vaginal creams in case of monoleal as well as trichomonas vaginitis. And the last antifungal drug, sodium thiosulfate. Sodium thiosulfate. It is said to be a weak fungistatic. 20% of the solution applied twice daily for 3 to 4 weeks in case of pityriasis versicolor has produced a very good results. However, normal pigmentation of the skin takes longer to return. So that important point that you need to remember. So pityriasis versicolor, there will be a slight change in the color of the skin. So for the normal skin color to return, it takes some time. So with this, I have concluded antifungal drugs. Hope you have understood. Till then, take care.